Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. You must have heard the term H3N2 frequently in recent days. You as a practitioner must be having many queries regarding this virus and illness. So to solve your queries, I came up with this video on influenza type A H3N2. Most of the influenza pandemics are caused by influenza type A viruses. Influenza type A viruses have two antigenically important surface proteins. These are hemagglutinins and neuraminidase. There are 18 different types of hemagglutinins and 11 different types of neuraminidase. Depending on combination of these proteins, influenza type A virus is further divided into subtypes like H1N1, H9N2, H7N9, H3N2, etc. This virus belongs to group of swine flu causing viruses along with H1N1 subtype. So natural host of this virus are pigs and it spreads through respiratory droplets. Virus is transmitted to human through inhalation of infected respiratory droplets, touching the infected surfaces, eating undercooked infected pork. Human to human transmission can occur through inhalation of infected respiratory droplets and touching infected surfaces. Incubation period of 1 to 4 days have been reported. Symptoms are similar to common flu like fever, cough, body ache, headache, throat pain, running nose or rhinorrhea, malaise, and sometimes patient can present with diarrhea also. Few patients develops complications. Most common complication is pneumonia. Along with symptom of flu, pneumonia presents with severe cough, breathlessness, and hypoxia. X-ray findings in pneumonia are perihilar and peribronchial infiltrate, which looks like this. In severe cases, there can be interstitial infiltrates, which looks like this. Findings are usually bilateral as opposed to bacterial pneumonia, which is usually unilateral. Other less common complications are rhabdomyolysis, encephalopathy, myocarditis, pericarditis, toxic shock syndrome, and sudden death, which may be due to cytokines dysregulation and superadded bacterial infections. Who are at high risk of development of these complications? This high risk group include adults 65 years and older, children younger than 5 years old. Complication rate are even higher in children younger than 2 years old. Mortality is highest in infants less than 6 months old. Patient with neurologic and neurodevelopmental conditions, especially children. Chronic illnesses like asthma, blood disorders such as sickle cell disease, chronic lung disease such as chronic obstructive pulmonary disease and cystic fibrosis, endocrine disorders such as diabetes mellitus, heart disease such as congenital heart disease, congestive heart failure, and coronary artery disease, kidney diseases, and liver disorders. People who are obese with body mass index of 40 or higher. People younger than 19 years old on long-term aspirin or salicylate containing medications because these patients are prone to develop race syndrome. Patient with weakened immune system due to diseases such as HIV or AIDS, leukemia, or patient on immunosuppressive medications such as chemotherapy or corticosteroids. Pregnancy and 2 weeks postpartum is also an high risk period. Diagnosis confirmation is done with RT-PCR of throat or nasal swab or tracheal aspirate in intubated patients, viral culture, and demonstrating four-fold rise in neutralizing antibodies titer to hemagglutinin and neuraminidase. Out of this, RT-PCR is the most common method to confirm the diagnosis. But RT-PCR is not done in each and every suspected patient. Indications for RT-PCR are discussed later. Severity of the disease is assessed with X-ray test or CT thorax, arterial blood gas analysis, complete blood count, renal function test, liver function test to look for presence of multi-organ failure. For management, patients with symptoms of respiratory tract infections are divided into three categories. Category A patients are one who present with mild fever, usually less than 38 degrees Celsius or 100.4 degree Fahrenheit, along with symptoms like cough, throat irritation, body ache, headache, diarrhea, and vomiting. Swab collection for RT-PCR is not indicated in category A, and they are treated symptomatically without oseltamivir. Patients are put into home isolation and reviewed after 24 hours to look for progression of illness. Category B patients are those who, along with category A symptoms, present with fever more than 38 degrees Celsius or 100.4 degree Fahrenheit, severe sore throat, and rhinorrhea. Swab for RT-PCR is taken in selected patients belonging to high-risk group. They are treated with oseltamivir, but hospitalization is not indicated if there is no worsening. Category C patients are those who, along with category B symptoms, present with breathlessness, chest pain, hemoptysis, hypotension, cyanosis, or altered mental status. Swab for RT-PCR should be collected from all such patients. Hospitalization and treatment with oseltamivir is indicated in these patients. Indication for mechanical ventilation are severe respiratory distress or oxygen saturation less than 90% or partial O2 pressure less than 60 mm of mercury with FiO2 0.6 or more. ARDS protocols are followed for patient on invasive mechanical ventilation. Antivirals used in influenza are neuraminidase inhibitors. There are two such antivirals available for use in influenza, oseltamivir and zanimivir. Dose of oseltamivir is 75 mg per orally every 12 hourly for 5 days. Maximum total daily dose is 300 mg. Doses of oseltamivir need to be adjusted in presence of renal failure. Zanimivir is given through inhalational route. Dose is 10 mg inhaled every day for 5 days. It is not recommended in asthma or COPD as it can induce severe bronchospasm in these patients. It should not be given through nebulization. Antiviral treatment should be started within 24 to 48 hours after the onset of symptoms when indicated. Safety in pregnancy and lactation is not confirmed, but these patients belong to high risk group and benefits outweighs this risk. Hence, they can be used in pregnant and lactating mother. They can be used for prophylaxis but not recommended routinely. For prevention of influenza, one should wear mask, cover face and nose while sneezing and coughing, drink plenty of water, and do frequent hand wash or sanitization with alcohol-based disinfectant. And one should avoid social gatherings, touching eyes and nose, crowded places, shaking hands or hugs, spitting in public places, and sitting very close to each other. Person can shed virus from 1 day before to 7 days after the onset of illness. Children and immunocompromised person can shed virus for longer period. If illness is prolonged or complicated, then person can remain infective till resolution of illness. Other way of prevention is influenza vaccine. Influenza vaccine is an inactivated viral vaccine. Composition of influenza vaccine is rebalanced periodically to include recent circulating strains. There are separate recommendations for vaccine composition for northern and southern hemisphere. It can be given to anyone 6 months and older. Children 6 months through 8 years of age may need 2 doses during a single flu season. Everyone else need only 1 dose each flu season. It takes about 2 weeks for protection to develop after vaccination. Influenza vaccine does not cause flu. Influenza vaccine may be given at same time as other vaccines. Contraindications are history of hypersensitivity to previous vaccine and history of Guillain-Barré syndrome.
Thank you for watching this video till the end. If you have any query or suggestions, please write it down in the comment section. If you like my work, please like this video and share it with your friends. And to get notified about next video upload, please subscribe to this channel and hit the bell icon. Till next video, take care and keep learning.